Bismillahirrahmanirrahim. I would like to express my heartfelt gratitude for all professors and colleagues in Ain Shams University Hospital Nephrology Department for inviting me to this prestigious Intervention Nephrology and Critical Care Conference under the portage of Professor Dr. Huwaida Shinnawi. I also would like to thank all the professors in the honorary president, moderator, and organizing committee for giving me the chance to share my case today. Let's start. We have 34-year male patient with no known previous medical or family history. He was brought by the national ambulance with a history of disturbed conscious level and desaturation at home. His attendant gave history that he had been vomiting and he had abdominal pain for the last 3 days before presentation. Physical examination and vital sign assessment in the ER showed that the patient had hypoxia. His oxygen saturation was 86% on room air. He was agitated, deeply jaundiced. Lung examination showed bilateral basal diminished air entry on auscultation. Heart and abdominal examination was unremarkable. His laboratory investigation in the ER showed high white blood cell count, leukocytosis 21,000, low hemoglobin was 8, evidence of acute kidney injury, his creatinine was 1.4 milligram, and there is evidence of acute hepatitis, his liver enzyme, ALT was about 4,000, AST about 1,600, his total bilirubin about 870 micromole, about 35 milligram per deciliter, and the direct bilirubin about 500 micromole. His ammonia level was high and albumin was low. He was admitted in the ICU as a case of acute liver cell failure with hepatic encephalopathy. He continued to be agitated, so he received flumazenil, and we started for him hepatic encephalopathy measure with low-dose methylprednisolone for the assumption of possibility of drug-induced acute hepatitis, in addition to antibiotic cover for possibility of underlying infection. He received broad-spectrum antibiotic cover. Bedside abdominal ultrasound showed grade 2 nephropathy. His liver was normal size, and there is no evidence of intra or extrahepatic biliary dilatation, mild splenomegaly, minimal fluid collection in the peritoneal cavity, and bilateral moderate pleural effusion. His chest X-ray study was normal, and we did also echo for him, bedside echo. There was no evidence of cardiomyopathy, no wall motion abnormality, and his ejection fraction was normal. In the second day in ICU, he was maintaining his saturation on 5 liter simple mask oxygen, but progressively he had desaturation, and he was shifted to high flow oxygen by non-replacing mask. He had fluid intake about 1.9 liter in the first day, and urine output about 700. And we give him fresh frozen plasma and bagged RPC for the possibility that we can need to do a biopsy, renal or liver biopsy. Following up his laboratory investigation, second day, the white cell count was 38,000, progressively increasing. Hemoglobin was dropping, 5.3. His INR was deranged, 1.3. The INR was high, PTT prolonged. And the creatinine jumped the second day from 1.4 on presentation to 4.6 milligram up to 5 milligram by the third day of ICU admission. His liver enzyme still high. His bilirubin is progressively rising. Total bilirubin now about 60 milligram per deciliter, 1,100 micromole. And he has albuminuria. Still, there is no hyperkalemia, no metabolic acidosis. There is also evidence of intravascular hemolysis. The reticulocyte count was high, LDH was high, and haptoglobulin was low. The CPK total was high, and myoglobin was high. And this is a slide which shows serial follow-up of his laboratory investigation. As you see here, how progressive lies in the total bilirubin and from 800 to 1,100. We did urine analysis. There is hematuria, but most probably the patient was agitated during insertion of the Foley's catheter. He has +3 protein in urine. What could be the differential diagnosis for this case? Acute liver cell failure with acute kidney injury, intravascular hemolysis. We have evidence of underlying infection as the white cell count was high, the CRP was high, and procalcitonin level was high. Although we collect bank cultures, there was no culture positive, and there is no localization for the source of infection. What could be the differential diagnosis for this case? As we see, the differential diagnosis of acute hepatitis is either viral-induced hepatitis, autoimmune hepatitis, metabolic, or hemophagocytic lymphohistiocytosis, or drug-induced hepatitis or miscellaneous disorder. So we have a case of acute fulminant hepatitis due to various etiology as a possibility, acute kidney injury either due to sepsis or due to intravascular hemolysis with hemolytic crisis, or could be due to rapidly progressive renal injury or systemic disease as Wilson disease. And here, following up the ABG, there is no evidence of metabolic acidosis. The lactic acid was high, and the ammonia level was progressively increasing. Thyroid function was normal. We did acetaminophen level, paracetamol level, it was normal to exclude drug-induced hepatitis. If we review the literature for Wilson disease is characterized by acute hepatitis, and neurological disorder is mainly extrapyramidal manifestation. There is COMS negative hemolytic anemia, as in our case. Liver enzyme is significantly elevated in the range of 2000, and maybe there is rapidly progressive renal failure in Wilson disease. To differentiate the neurological manifestation of Wilson disease from the hepatic encephalopathy of acute liver cell failure is very difficult. But actually, we can realize that Wilson is mainly extrapyramidal. There is dysarthria, Parkinsonian, tremor, ataxia, seizure, which is not present in our case. And we know that the clinical pattern of Wilson disease, there is hepatic manifestation, neurological manifestation, as we said, psychiatric and other system manifestation, as LI, there is a Kaiser pressure ring, and renal abnormality. Wilson usually affects the kidney in the form of renal tubular acidosis, proximal renal tubular acidosis, and Fanconi syndrome, which is not present in our case. And there is a scoring system for Wilson. We cannot fulfill all the criteria. We don't have neurological extrapyramidal manifestation. We don't have, we measure the ceruloplasmin level. We have only COMS negative hemolytic anemia and elevation of the liver enzyme. And we didn't do liver biopsy to assess liver copper content. We assessed the serum ceruloplasmin level. It was low normal, so it is borderline. We measured the urinary copper, but unfortunately, the patient at the second day, he was oliguric and followed by anuria. So we cannot collect accurate 24-hour urine forces for the urinary copper. We don't have enough sample to assess a urinary 24-hour copper. So, and also even the level of ceruloplasmin is non-reliable for the diagnosis of Wilson disease in the presence of acute hepatitis, as it is acute phase reactant, so it can be elevated in infection and it could be depressed due to severe hepatic synthetic dysfunction. And the level is low normal. As we said, the spot urine collection is inaccurate for the diagnosis of Wilson disease, and we need to have adequate urinary sample. But the third day of hospital admission, the patient Glasgow-Coma scale was 7/15. The anesthesia team decided to intubate the patient for protection of the airway, and he was started on mechanical ventilation. His blood pressure started to drop, so they started for him inotropic support. The patient continued to be anuric, and his serum creatinine rise up to 5 milligray. There is said evidence of intravascular hemolysis. LDH was high, reticulocyte count high, and serum haptoglobulin was low. What further workup we could do? What investigation further we could do to reach to the diagnosis or to narrow the diagnosis? What could we do? We will follow a bullet question, autoimmune marker, virology screen. Could we need renal biopsy, liver biopsy, all of the above? Actually, we did all of the above, except the biopsy. We did hepatitis profile, we did hepatitis A, B, C, we did cytomegalovirus, Epstein-Barr virus, we did the leptospira antibody, all was negative, were negative. And also we did autoimmune marker, ANA, we did DNA, ANCA, anti-smooth muscle, we did anti-mitochondrial antibody, all the autoimmune marker were negative. We did malaria film to exclude parasitic infection, also negative. As we said, Leptospira, Epstein-Barr virus, cytomegalo, all were negative. And this is the autoimmune marker we had done. We did 24-hour urine protein in the first day. It is about 500 milligram in 24-hour urine protein. ANCA was negative, ANA was negative, Leptospira negative. So we still couldn't narrow the differential diagnosis. We're still in the dilemma of fulminant acute hepatitis, intravascular hemolysis, CUMS negative intravascular hemolysis. We have bilirubin cast could induce acute kidney injury. We have hemoglobin cast could induce acute kidney injury. Underlying sepsis could be the cause also of the acute kidney injury. In the presence of oliguria and volume overload, and the patient was on inotropic support, we started CRRT. We started to have dialysis therapy and renal replacement therapy by CRRT. On the 5th day of ICU admission, the bilirubin was progressively rising, and we are afraid of brain edema and high serum ammonia levels. So we decided, with the consultation of the hepatologist, to do thrombotic plasma exchange. The target behind thrombotic plasma exchange is removal of the inflammatory molecule, removal of the bilirubin, and other possible albumin-bound toxin. We did thrombotic plasma exchange daily, about 3 liters in average each session, and we use fresh frozen plasma and albumin as a replacement fluid. The duration of each session about 5 hours, and we performed the thrombotic plasma exchange daily for 3 consecutive days until the patient start to improve clinically. We did high volume thrombotic plasma exchange, which is about 15% of the ideal body weight of the patient, from an average from 6 to 8 liters per session, which is expected to remove about 90 to 98% of the toxin in the intravascular space. And this is a picture of the CRRT machine we use for thrombotic plasma exchange, and the effluent, as we see, the bilirubin dark green color in the effluent fluid. And if we return to the evidence why we did thrombotic plasma exchange, because the American Society for Apheresis recommend for acute liver cell failure to do high volume thrombotic plasma exchange as a first line of treatment is evidence 1A. And also, if we put the suspicions of Wilson disease, thrombotic plasma exchange is one of the modalities used for the treatment of Wilson disease. This is a paper published in the World Journal of Hepatology 2021 for the value of thrombotic plasma exchange in liver cell failure. And as we see here in the abstract, thrombotic plasma exchange has been shown to reduce the level of inflammatory cytokine, modulate adaptive immunity with potential to lessen susceptibility to infection, and reduce the level of albumin-bound and water-bound toxin in liver cell failure. And it helped recovery of the patient from the multi-organ failure and to reduce the vasopressor requirement and improve the survival. We know the pathogenesis of multi-organ failure in acute liver cell failure is due to excessive systemic inflammation and dysregulated immune activation triggered by both microbial and non-microbial factors. We have damage-associated molecular pattern, and we have pathogen-associated molecular pattern. This is they are released in the presence of superimposed infection or bacterial translocation with activation of the cytokine and release of cytokine store, which lead to multi-organ failure. And this is a cartoon which shows the value of thrombotic plasma exchange. It removes the inflammatory cytokine, it decreases damage and molecular associated pattern, and it protects the patient from cerebral edema, help recovery of acute kidney injury, and any cardiac dysfunction. It removes cytokine, endotoxin, bilirubin, bile acid, ammonia, albumin-bound toxin. We know that there are other therapy for acute liver cell injury, like extracorporeal albumin dialysis, and we have the MARS system for acute liver cell failure. But when we consider the difference between thrombotic plasma exchange and the extracorporeal albumin dialysis and MARS, we found that the thrombotic plasma exchange actually is logistically less complex, and it is easier to be initiated than other methods. In addition, in thrombotic plasma exchange, we can give the patient fresh frozen plasma, which corrects the coagulation disorder. And it removes the immune complex, it removes larger molecule protein like the immune complex. As the patient was suffering hand in hand with acute liver cell failure, with acute kidney injury, so we need to give replacement therapy via CRRT as the patient was in inotropic support. So we have both therapy going together to help to improve the patient general condition and recovery of the patient from the multi-organ failure. Still, the patient till the 5th day he is in ICU on mechanical ventilation in inotropic support, and we serially follow up his laboratory investigation. We see here there is improvement in the white cell count, decline to 14,000 from 38,000. Still, the creatinine because of the dialysis slightly improved. There is no hyperkalemia, no metabolic acidosis. And we see here in this slide that the liver enzymes start to improve, the bilirubin start to decline, and even the ammonia levels start to improve. We did CT brain to exclude brain edema. There is no evidence of edema, and we plan to continue on the same management, therapeutic plasma exchange, CRRT, and trial of weaning with the other supportive measure. On the 7th days of the hospital admission, the patient clinically improved and the anesthesia team were able to extubate the patient. And if we see his laboratory investigation on the 7 days, the total serum bilirubin declined from 1,000 to 500, ALT declined from 4,000 to 200, ASD declined from 1,600 to 122. But unfortunately, there is a rise in the serum lipase level, which give a clue to underlying acute pancreatitis. Still, we send, as we said in the first slide, we send all the hepatitis profile. The hepatitis A and B and C came negative, but hepatitis E virus antibody is still pending as it is done outside our facility. We did CT abdomen for acute pancreatitis, and it showed evidence of acute pancreatitis, and the patient continued to receive supportive therapy. We repeated the serum ceruloplasmin, the same level, low normal level. Haptoglobulin still low, indicating still ongoing evidence of intravascular hemolysis. Actually, when the INR improved, we found here the INR is 1.3. We offered and we counseled the family about doing renal biopsy. We want to do renal biopsy to diagnose the cause of acute kidney injury. But unfortunately, the family were not willing to go in the procedures. They didn't give the consent. So we cannot do renal biopsy for this patient to diagnose the cause of acute kidney injury. On the 8th day of hospital admission, the patient developed fever. We had to remove the femoral castor, and we sent bank culture for him, and we started him on broad spectrum antibiotic, and we insert right jugular castor to continue dialysis as the patient continued to be anuric. As we see here, we sent culture, blood culture came negative, only the sputum culture came positive. The patient continued to receive dialysis. We shifted him from the CRRT because he became off inotrope to intermittent hemodialysis. And by the 15th day, 2 weeks after hospital admission, the serology for hepatitis E virus, IgM, came positive. This is a slide which shows IgG and IgM came positive. So this finally we can reach the diagnosis. What is the cause of his acute liver cell failure with complicated acute kidney injury, IgE, IgM, and IgG positive. And if we review the literature, hepatitis E virus affects about 20 million individuals every year. And it is responsible for the death about 44,000 by 2015 due to viral hepatitis. Renal manifestation of hepatitis E among immunocompetent patients. They are able to establish the hepatitis E virus particle in the urine of infected patients. And the manifestation of hepatitis E associated renal affection is either pre-renal or intrinsic renal disorder. As we see here, pre-renal affection due to volume depletion, or intrarenal acute tubular necrosis, bile cast nephropathy, hemoglobin cast, especially with the presence of G6PD. Our case, the G6PD was low normal also, so there is a possibility of G6PD deficiency. And this could be the cause of acute kidney injury, hemoglobin cast, or bilirubin cast nephropathy. There could be with hepatitis E infection, glomerular affection. And there is hepatitis E virus-mediated renal injury by the interaction between the immune cell and the renal epithelium. And this is a cartoon which shows how there is a crosstalk between the renal epithelium and the immune cell, which lead to cascade of inflammation and tubular injury and epithelial damage and acute kidney injury. So we have a case of acute liver cell failure due to hepatitis E virus infection, which lead to accumulation of toxin and depletion of glutathione in the presence of G6PD deficiency, precipitate intravascular hemolysis, Combs negative, heme pigment caused direct tubular proximal toxicity with acute kidney injury in addition to the bile cast nephropathy. And the management is mainly supportive treatment till the patient recover from the infection. Thank you for your attention, and I hope my case was fruitful for you, and we will open the floor for discussion after the presentation. Thank you much.
Thank you so much دكتورة دولت. دكتورة دولت واحدة من سفرائنا المهاجرين المجتهدين جدا، وسعدنا بيكي your fruitful case presentation. And now discussion is open for this case. If anyone have any question for دكتورة دولت. دكتورة
السلام عليكم، ازي حضرتك يا دكتوره هويدا؟ ازي حضرتك؟ الو، السلام عليكم. الو الو،
ايوه احنا سامعينك يا دولة. دكتورة دولة.
ازي حضرتك يا دكتوره هويدا؟ ازي حضرتك؟ انا والله I'm very pleased to be invited to this conference. I would like to thank all the organizing committee for giving me the floor to share my presentation today, and I hope the case was good, and we can open the discussion if anyone want to ask about the differential diagnosis of, or if any the other differential diagnosis, because we have only evidence that the patient has hepatitis E infection, which could lead to acute liver cell failure and acute kidney injury.
Dr. Dawlat, discussion is already open, and you have one question here.
What? I can see the question. I didn't see any question provided in the screen.
بالنسبه لتحليل فيروس ايه بطايتس، احنا يعني التحليل ده مش موجود عندنا. الحاجه الثانيه ان في الحاله كان عندنا لوكوسايتوزس، مع ان الفيرال انفكشن بتعمل لوكوبينيا او بتبقى نورمال ليكوسيتيك كاونت. الحاجه الثانيه، هل كان في دراج هيستوري مع الحاله دي، انها كانت بتاخد دراجز قبل الموضوع ده ما يحصل ولا ما كانش في دراجز؟ واحتمال الاسكيميك هيباتيتس موجود في حاله السيبسيس والهايبوتنشن اللي موجود، ان ممكن نحط احتمال الاسكيميك هيباتيتس.
Thanks for all this suggestion. Actually, we don't know the cause of the leukocytosis. We don't have explanation. We take pan culture and we search for the source of infection. We couldn't localize any source of infection. We don't have clear explanation for the increase in the white cell count and the evidence of high CRP and high profile symptoms. This is one thing. The second thing, there is no any history of drug. There is no drug history. And we did the paracetamol level to exclude paracetamol toxicity, but the paracetamol level was normal, because this is we commonly face taking the paracetamol as a suicidal attempt. So there is no evidence of paracetamol toxicity, and there is no evidence of drug history from the attender when he came and presented to the ER. Could be ischemic hepatitis, could be a possibility, but at first his blood pressure was maintained يعني on presentation to the ER he was not on inotropic support, his blood pressure was normal. He started to be on inotropic support on the 3rd day of ICU admission. So we cannot incriminate ischemic hepatitis as a cause of acute liver cell failure. You hear me?
Thank you. Thank you so much, Dr. Dawlat, for your fruitful case presentation. And now we have an appreciation certificate for you for sharing us.
Thank you, Dr. Huwaida. I would like also to thank Dr. Haitham Azzat and Dr. Noha, the chairperson, for this session. I think this is a great opportunity for me to learn by sharing this intervention nephrology and critical care conference. And I congratulate all the department for their great effort for this international conference.
Thank you so much.
Thank you, Dr. Huwaida.
Now,